Welcome, everybody. Thank you so much for being here. I'm very excited to be kicking off this program because I know the caliber of people that are here, both here in the audience that are going to speak. I think it's going to be a great evening. I was honored, a few years ago to get a call from Randy Olson, our former chair, and Jeff Petty, our current chair, asking me to take on, to step into a role and fulfill a dream that Alan Crandall had. Which is to understand glaucoma at a deep level, to find better treatments for our patients who need that. And as a clinician scientist, my first and foremost goal is to help my patient in front of me. It gives me an advantage because I really feel the impact of this really terrible, difficult disease when we know it's the leading cause of blindness and where therapies still are falling short, and to apply that in the lab. And so when I was asked to come back and help, lead this center with the thankful donation of the Burton Foundation and others as well, I took it as a very important task, And the task given to me was we want to build a world-class research and clinical program to unlock the challenges in glaucoma. And I think many of you are aware of that. And through the last 4 or 5 years now, and you're going to hear about this today, we've been able to bring on the best and the brightest scientists here. Now, fortunately, we already had many of them here, actually. You're going to hear from that already. We already had some amazing science being developed here that will really change the course of this disease. Science does take time, but we're trying to accelerate that with how we do and how we study. And you're going to hear from some fantastic individuals. I have the privilege to help, network and develop. I don't like to use the word lead because really we're a team together and we're really assigned to do the most important task. Some of you may know I did a fellowship here with Alan. And so coming back for me to the Moran is a special place. I've been fortunate to travel many places around the world and see how medicine is practiced, see how science is done, see how people treat patients, and I always hold the Moran to me as the standard for so many reasons. Being able to do this here at the Moran, it's a very special place. We're only scratching the surface here, but I'm very proud of the team that has come. We do have a few focus areas that we are focusing on. One of my areas and a passion for me has been improving our surgical approaches to glaucoma, creating safer and less invasive ways to treat glaucoma earlier to help the lives of our patients. And we've been fortunate to be a center now over the short time to do these things. We're all looking for ways to protect the nerve in ways that we can't right now. We have some great work being done. You're going to hear about that again today as well. And of course, genetics unlocks a lot of the mysteries in disease. A very robust translational center we have here as well. And of course, we are looking not just developing work for those that are privileged to have access to it, but also global. And you're going to hear that aspect of it as well. So these are some of the real pillars amongst the initiatives here, and we've certainly grown from there. It's pretty incredible, and we have, I'm sure hopefully we can distribute our annual report, but in the last, just the last 5 years, you can see how many partners we've developed. We've relationships with 80 plus global partners in the top industry partners in the world. We have tremendous amount of studies and publications coming out. So the work is still the road is still long, but we have already seen, the world of glaucoma come here. So, the task that Jeff and Randy had bestowed upon me, I think we're already seeing the fruits of that happening, where those that are interested in doing research are bringing their research to the Moran, whether it means in the lab, at the bench top, or whether it means in the cloud with AI and data, or whether it means at the bedside with the patient. Our goal and our dream is becoming a reality to reach that. And so this is our devotion. I mean, as you can tell, I only sleep about 4 hours a day, but I literally, and you can ask my family that, I spend most of my waking time thinking about helping my patients in that chair. And that's my mission on this earth, honestly. I'm not good at anything else. Really, I'm not. I tried playing football. I tried to write. I can't do music. But I think maybe God put me on this earth to try to make an effort to ease the suffering of this really difficult disease, and to work with people who are genuinely motivated for a greater cause to be here. The impact will be beyond what they're seeing in front of them, but to the world in front of them. So, that's my privilege. Honestly, I feel like a shivers here coming here, and it's a real honor for me to be able to get this program started along with Jeff. So thank you for being here, and we're all here for in this together. So I'm looking forward to the rest of the program, and I will hand it off to I have two of my fellowship preceptors here. Jane Durkin, where's Jane? Jane is here somewhere. Jane Durkin and Norm Zabriskie and Alan Crandall. Those are my three mentors I've had in glaucoma. The late Alan, of course, is with us all here, but we're lucky enough to have Norm and Jane here. So Norm, I'm going to hand it over to you. Thank you so much.
Thanks, Dr. Ahmed. So my name is Norm Zabriskie, and it's great to be here with you, and it's so wonderful to have all of you here with us. We just are so grateful to you for taking of your time to be here this evening, and just have us kind of talk with you a little bit about the things that are going on here at the Moran Eye Center. And I've been asked to give a short overview of glaucoma. Glaucoma is a big topic. We're going to talk about it in a short period of time. But I think mostly our goal here is to provide some context for what you might hear as the evening progresses about how we're looking to better diagnose and treat this disease we call glaucoma, and how we're looking to the future to improve all of those diagnostic and treatment modalities. So with that in mind, let's start with the definition. This is a definition that was presented by the American Glaucoma Society back in a paper in 2020. And in this definition, they say that glaucoma is a group of chronic, often asymptomatic diseases that damage the optic nerve, and if left untreated or insufficiently treated, can lead to irreversible disability, vision loss, and blindness, okay? So I think what we're here to do tonight is to kind of talk about what glaucoma is, and especially how we're treating it and how we hope to treat it more effectively in the future so that we can avoid this, avoid the disabling part of glaucoma as we treat it more effectively. So the definition said that glaucoma is all about the optic nerve. And this is a picture of an optic nerve, a very healthy optic nerve, the blood vessels coming out of that nerve, nourishing the retina. But this nerve here, this is a very healthy optic nerve, okay? And what it consists of is about 1.2 to 1.5 million nerve fibers that are starting in the retina and then coalescing and passing through this optic nerve and then proceeding on to the brain. And we can kind of think of it like this, I think. This is just a pictogram. And all these lines represent these individual axons, these nerve fibers that are originating in these ganglion cells in the retina and then coming to the optic nerve and then passing on to the brain. And notice how they're kind of, the peripheral ones are kind of in this arcing pattern. And we're going to see that show up here in a little bit. They kind of arc around this big bundle of nerves here and go into the optic nerve and then onto the brain. Now this is another optic nerve, and it looks different than the first one because it's got this kind of central portion here that's hollowed out. And we call that cupping, okay? And glaucoma causes the optic nerve to cup. That's one of the characteristic changes in the optic nerve that we see with glaucoma. And so this nerve here has a bigger cup, but it still looks quite good and robust. And this, what we call the rim of the optic nerve, is still quite symmetric. So this is still a very normal and healthy optic nerve. Different than the other, but still normal. And that's one of the kind of the diagnostic dilemmas of glaucoma, is trying to differentiate what is an abnormal optic nerve when there's such a wide range of normal. Now this optic nerve also has this cupping to it, but something different is going on in this optic nerve. That right here, I hope you can appreciate that, but this kind of rim tissue, it thins out right there. In fact, it almost disappears, and these blood vessels are laying right on the rim of that optic nerve. And so this is, we call it optic nerve thinning, or a notch that is formed. And this is just a classic glaucoma finding there, where the nerve thins out in these localized areas here. So this is a glaucomatous optic nerve. This one is a severely damaged optic nerve from glaucoma. In fact, it's hard to identify really any normal tissue there at all, okay? So glaucoma can get very advanced, but we definitely want to stand in the way of that. Another finding on the optic nerve that's really characteristic of glaucoma is like this little hemorrhage. Can you see that little hemorrhage right there? We call that a disc hemorrhage or a nerve hemorrhage. And if we look in there and see that, that is a really characteristic and typical finding of glaucoma. So glaucoma is a disease of the optic nerve, and so we need to know and learn how to assess the optic nerve to the best of our ability. We've talked about one way, which is to look at it, as these pictures demonstrate. Another thing we'd like to do with the optic nerve is to determine how well it sees. How well does it function? And so to do that, we do these beloved visual field tests. Any of you that have been through these, you know how much you love them. We don't make any friends with these, but they are absolutely critical in terms of assessing how well that optic nerve is functioning. These are two normal visual fields. Everything about them is normal. This area right here is the normal blind spot. That's where the nerve comes into the back of the eye, and it has this blind spot. This is the right eye. This is the left eye. Perfectly normal. We love it when they look like that. Now, in contrast, these are visual fields that have been affected by glaucoma. You can see these areas here that are in the dark, representing areas of their visual field where this patient doesn't see as well. And notice how they kind of have that arcing character to them. That's representative of those arcing nerve fibers that we showed in that pictogram. And so this just kind of follows that pattern. This is a very typical looking glaucomatous visual field. And we follow these, we repeat them to see if the visual field is staying stable or if that defect is in any way getting bigger, indicating progression of the disease. We'd also like to know more about the anatomy. And so we have this great newer technology called optical coherence tomography, or OCT. And this great imaging modality actually measures the thickness of the optic nerve for 360 degrees. And it kind of plots it out for us here. And then in an excellent way, it compares all of those points to a normal database and lets us know, compared to, quote, normal, does this optic nerve look normal or not? Does it measure normal or not? Here we got everything in green. Green is good, as I say. This is a very normal looking OCT in each eye, right and left. And we can compare that to this one. And notice here that we start to see some of these quadrants measuring out in red, meaning that in those areas, compared to a normal database, that nerve is definitely thinner than what we expect it to be. And that's very characteristic of glaucoma. So this is a great modality, and you're going to hear more about fields and OCTs here in a little bit. So now that we know about assessing the optic nerve and that glaucoma is all about the optic nerve, okay, so what do we do about that? And that's where pressure enters into the conversation. We spend a lot of time, as you know, talking about pressure. It's actually not part of the definition. It is just the most important risk factor for glaucoma. Higher the pressure, the more risk there is of glaucoma, okay? There are other risk factors. This is in no way an exhaustive list, okay? But there are many others. There are ethnic differences. There are family history and genetic differences. Thin corneal thickness can be a predictor of glaucoma, okay? But the one that is the most important, in part because it's the one we can modify. We can change the pressure. We can lower the pressure. And so pressure is really the most important modifiable risk factor currently to treat glaucoma. We know that there are more to do with pressure in glaucoma, because many people have glaucoma and never have a high pressure, okay? We're trying to understand more about those patients. But lowering the pressure is still the fundamental treatment for glaucoma. So let's talk about, if we're going to lower the pressure, does it make a difference? Does lowering the pressure decrease the risk of vision loss? And the answer to that is an emphatic yes. It is yes, irrefutable, absolutely. Lowering the pressure is a beneficial treatment. It's not a cure, but it absolutely helps. And we know that because of studies like these, big, well-executed, well-done studies that ask the question, is pressure part of the pathologic process of glaucoma? And is lowering the pressure an effective treatment to reduce vision loss in glaucoma? And again, the answer to both of those is emphatically yes. And so we're going to spend time and effort to lower the pressure and try to halt a person's glaucoma progression. Now, let's talk about, well, why is there pressure in the eye anyway? If we're going to lower it, why do we even have to deal with pressure? And this picture here is just a cutaway version of the eye. We've got the cornea here, we've got the iris here, and we've got the lens of the eye here, where cataracts form. And we have this dilemma, really, because these structures, the lens, the cornea, they need to stay clear because we've got to see through those, right? So those structures need to stay clear, but at the same time, they need nutrition and oxygen, just like other tissues in the body. But in these structures, we can't have blood vessels coursing through them, bringing that nutrition and oxygen like in other tissues in the body, again, because they have to stay clear. So to overcome that, the eye has this amazing process where a fluid called aqueous is produced in these structures here, which is called the ciliary body. And that aqueous is rich in nutrients and dissolved oxygen. And that aqueous flows around the iris. It fills this chamber here. It envelops the lens. It envelops the inner surface of the cornea, delivering, again, nutrients and oxygen to those structures, okay? And so that can create a pressure. And so since that fluid is always being produced, it's got to have a way out, okay? And so there is an outflow system. This is just another cutaway. Here's this ciliary body where this fluid aqueous is produced. It's filling the anterior chamber. It's coating the lens. And it flows out through this real complex structure here called the trabecular meshwork. We're going to hear more about that later. And then it flows out through that structure, and then it gets collected in these veins, and then ultimately is taken to the outside of the eye, and kind of in the area where the white of the eye is, that fluid is absorbed back into the normal vascular system of the body, okay? So that is kind of this normal flow. We call that the conventional outflow pathway. Now, not depicted here, but there's another very important source of outflow, and that is that some fluid kind of sneaks out right here. It sneaks out through there. It's what we call the non-conventional pathway, all right? And that's another important way that fluid flows out of the eye, and we're going to talk about that more here in just a minute. So in glaucoma, especially in this primary open glaucoma, what happens is that there is some kind of functional block or obstruction of that trabecular meshwork, and that fluid that is always being produced just can't flow out as much, and there becomes a pressure imbalance, and pressure goes up in the eye. I kind of think of it as like water in a sink, and you've got water coming in through the faucet, you got water draining out through the drain, and if you're going to maintain that level the same, those two forces have to be balanced, okay? In this case of open-angle glaucoma, there's something about that tissue that's blocking the outflow. The pressure can go up and damage the optic nerve, and we call that glaucoma. Now, one thing that is a particular type of mechanism for blocking that trabecular meshwork is this process that we call angle closure glaucoma, all right? And in angle closure glaucoma, that fluid is being produced just like it always has to be, but for some reason there's like a functional block here between the iris and the lens, and that fluid that typically flows out here, fills the chamber, and then drains out here, it gets trapped behind the iris, and it pushes that iris forward, and that iris blocks that outflow, okay? And we call that angle closure, and we can treat that by putting a laser opening through the iris. That allows the fluid to escape. It fills this chamber, it pushes this iris back, exposing the drainage channel, and it can be an incredibly effective way at lowering the pressure in the setting of angle closure, okay? Now, so if we know that we've got pressure in the eye, we've got fluid always being produced, and we know that lowering the pressure is an effective treatment, how are we going to do that? And when I think about lowering the pressure, in my mind as I'm working with patients, I have this equation in my mind. This is the Goldman equation, the classic equation that calculates what the intraocular pressure is, that's this variable here, based on 4 contributing variables. We've got F, which is the rate of aqueous production. That's how fast, how much of that fluid is being produced, okay? So we got that variable. We subtract off that the outflow through that non-conventional pathway. So this variable U is the fluid that kind of sneaks out that alternate way. Then we've got the variable C. We divide by C. So C is a representation of how easily fluid flows out that conventional meshwork, okay? So we've got those 3, and then finally we have this factor here just stuck on the end, which is called episcleral venous pressure. And the way I think of that is that that's the pressure, you know, when the fluid flows out of the eye and it's time to get resorbed back into the regular blood circulation system. Well, the blood system has pressure too, right? We measure blood pressure. And so that fluid coming out of the eyes kind of got to push against that pressure to get fully back into this drainage, venous drainage system. So that's kind of the way I think of this episcleral venous pressure. So with this in mind, how can we manipulate those variables to lower the pressure, which is our goal? So let's start with the first of those. That is F, the rate of aqueous production. So to lower the pressure, we want to decrease the amount of aqueous production, right? Basically, we want to turn down the faucet on the sink. And in today, 2026, the main way we manipulate this variable to lower pressure is through medication. You look through that list. This is not exhaustive, but you look through that list, you'll probably recognize most, if not all, of those drops, okay? All of those eye drops there, they lower pressure by decreasing the amount of aqueous produced. That's the way they work, okay? That's the way those horrible pills work, Diamox or acetazolamide. If you've ever been on those, you know what I'm talking about. But they work very effectively, but again, through the same mechanism. They decrease the amount of aqueous production. We have one surgery that works in that area, and that's a laser treatment where you actually laser the ciliary body, and that decreases the production of that fluid, thereby lowering the pressure. So that mostly to manipulate F, to decrease the production of fluid, that lowers the pressure. We do that medically, okay, in 2026. Let's talk about the next one. We've got this variable U. That is the fluid that's going to sneak out that alternate pathway, okay? Now, that's always been there, but it really became important when these drugs were developed, especially this one, latanoprost or Xalatan. That came out when I was a resident in like about 1993 or so. And it didn't take much time in the clinic to realize that this was going to be a powerfully important drug. These drugs right here have really revolutionized the medical treatment of glaucoma, all right? And they do that by increasing the outflow through this non-conventional pathway, and they do it very, very well. And so we use these drops a lot. There's now an implant that can be surgically implanted that provides this particular drug over an extended period of time, okay? So that's a surgical way that these drugs are used. And then there's a newer surgical procedure where a stent is actually placed into that alternate pathway to try to increase the flow through there, okay? But still, most of our manipulation of this variable to lower pressure 2026 is done medically through these medicines, all right? Okay, just a couple more. We've got this variable here, which is, again, the facility of outflow through the conventional. This is the ease of fluid flowing out through that traditional conventional pathway. And it's really interesting that even though that is really the fundamental defect of most glaucoma, we have very little medical manipulation of that particular structure. We have pilocarpine, which is a very old drug. It's well over 100 years old, and it doesn't get used much anymore. We have a newer drug, notarsadil, that affects that outflow through that conventional pathway. But overwhelmingly, of late, the way we manipulate that variable to lower pressure is through procedural means. We have this laser treatment, SLT or selective laser trabeculoplasty, which has really emerged as just a powerful, powerful treatment for glaucoma and to lower and even out pressure. We're going to hear about that, okay? These other procedures that are kind of new applications of older procedures are really designed to increase the outflow through that traditional pathway. And then finally, these stents that you might have heard of, the iStent, the Hydrus, their target is that conventional outflow pathway to lower the pressure, okay? So with this variable, unlike these two, in 2026, the main manipulation of that variable is with procedures, okay? And really an effective treatment. And then finally, we've got the last variable, and this variable is fascinating to me because it's just kind of put on the end there, okay? So the episcleral venous pressure, it's normally around 8 to 12. There's only one drug that kind of works on that, okay? But it's interesting because no matter how much we manipulate these three, and we're better and better at manipulating those three, this one is just always there. It's just always there. It's kind of like the floor of how much we can lower the pressure by manipulating these. And sometimes we want pressure lower than that. okay? And so the only way we can do that is to do surgery where we basically bypass the whole system, all right? So when I think of these surgeries like trabeculectomy, like these drainage valves, I think of, we're making a new drain and we're bypassing the system altogether. And with one of these procedures is where we can really talk about getting the pressure low, okay? And so our goal with these is to try to make them safer. We know they're effective, but we want to make them safer, all right? So that they can have wide application. So in summary, we've talked about what glaucoma is. It's an optic nerve disease, okay? Talked a little bit about the optic nerve, how we assess it, and how we judge its function, its anatomy, okay? Talked about how we know the role of pressure, and we know that lowering pressure is an effective treatment, not a cure, but an effective treatment. And then we talked about using this equation, the various means available to us, medicine, laser, and surgery that we can employ to lower the pressure. And as we talk the rest of the evening, we're going to talk about how we're going to try to make all of those better and more effective for our patients. So again, thank you very much. I appreciate it so much that you're here. I'm going to turn the time over to Barbara Wirostko now, who's going to conduct our panel and the rest of the evening for us. So thank you very much.
Thank you, Norm. So I am Dr. Barbara Wirostko. I'm a clinician scientist, a glaucoma specialist here. I'm going to call up my clinical panel first so if they can come up and join me. And really what we want to do is take everything that Dr. Zabriskie has covered and apply it to what we are doing here at Moran. Some of our interests are what my colleagues are going to speak about. I myself am very interested in IOP fluctuation, home tonometry, and actually some of the polygenic risk score that you heard a little bit about. But this is really to highlight our panel. So you heard about those visual fields. Well, Dr. Stagg is really trying hard to make them more comfortable and see how we can make them more tolerable for you. Does it give us information that we can work with? So Brian, go ahead. Tell us what you're learning with the work.
Is that working?
No.
No? Just bring it closer. Yeah. So I'm Brian Stagg. I am just really grateful to be part of this group. It's a really great presentation so far. So my work is, using visual field, but really kind of broadly, my goal is to use technology to make sure patients get the right care. One of the biggest reasons people go blind from glaucoma is that they aren't diagnosed early enough, or the progression isn't found early enough, and then they don't get the treatment that they need. So how do we use technology to make sure that happens? And one of the most important parts of that is visual fields. So visual fields are really annoying to do, but they're really critical for us to see if a patient is losing vision from glaucoma. And if a patient is losing vision, that means we've got to get the treatment that they need. And so we've been trying a lot of different technologies. I'm not sure, we've got some of them here. I'm not sure if maybe some of you got to look at it. But we're trying different ways to make sure that we identify that glaucoma progression early and make sure that people get the treatments that they need.
Has anyone in the audience tried some of these VR headsets, these virtual reality? Good, good. You know, I think it's something that we can look forward to, right, in the future. Perhaps it'll be more accessible to patients?
Yeah, I think, so as the technology develops and as we get more information, the way we take care of glaucoma right now is not the way that we'll be taking care of glaucoma 5 years from now. The visual fields, I think, are going to be different, and the testing is going to be different. I think a lot more of it's going to be done at home, and we'll be able to use a lot more of the data. We have a lot more data available, and we'll be able to do, I think, better analysis of it. It's interesting, the machines that we use for visual fields now are the same, like basically the same machines we've been using for a long time. How long, Dr. Zabriskie? Over 30 years. Over 30 years, yeah. For sure.
So you may have heard some of us tell you it's sort of the totality of the evidence, right? It's the IOP, it's the function of the nerve, the visual field, but then it's also the structure. And as Dr. Zabriskie beautifully outlined, it's that OCT, it's the photos. And Dr. Chortkoff, I know you have worked really hard in our department to make it accessible, to optimize it, to get new innovations in. Maybe you can share how and when do you use OCTs?
Well, I'm thrilled to see so many people here just to start out. It is a pleasure to take care of people who are really interested and engaged in their care. And I think Moran is the best place to practice. And I think OCT is amazing. It's really been a game changer for us in ophthalmology. When I was practicing, when I was training, when I was old enough, I'm old enough to remember when we didn't even have this technology. We had the nerve. We could look at the nerve, which, as Dr. Zabriskie pointed out, can be very deceiving. We had visual fields, and we had the pressure. And then OCT came along, and it allows us to see and measure the structures in the eye. We knew the structures are there from pathology, right? We knew it from cadaver studies or taking tissue from the eye during surgery. But now we can see it in your eye. Right in front of us, we can tell what is happening at the level of these cellular structures. And we can measure them. We can see the thinning happening as the glaucoma changes the tissue in a very characteristic pattern. And what that allows us is the ability to really detect the glaucoma so much earlier than we have been able to do in the past. We can see that there's damage, and we can then watch those scans and see subsequent scans over time. We can see if there's change happening, even how fast the change is happening. Do we need to be more aggressive at lowering the pressure? And we can see if what we did worked. If we did surgery or we added a medication, we can look back and see, are we changing these structures? And by doing that, we can detect glaucoma changes probably 6 years. Some people say 6 years before it shows up on the visual field. So that's just valuable information for us to have. And then again, just being able to tell the rate of change of glaucoma is super important. We have a small percentage of patients that are rapid progressors, and if we need to intervene earlier and more aggressively on those patients, as opposed to the vast majority of patients who change more slowly over time.
And I think one thing that Dr. Chortkoff is mentioning, which is really critical, is that we can use the OCT to pick up damage before it appears on the visual field. So again, it's before you're actually losing part of your vision or having a visual impact. And then it really comes down to, so if somebody's got some visual field changes, or if their OCT is changing, you heard Dr. Zabriskie walk us through the different treatments, but this again is really an area that you're going to be hearing more and more about being offered to patients, is the laser. So Dr. Nakatsuka, walk us through your work.
Yeah, hi everyone. I'm Austin Nakatsuka. I'm a clinician here. First off, I just want to say I know a number of you are my patients here in this audience. It's so exciting to see you here. I know that you've heard me talk about this technology to you in clinic. I'll probably hear a bunch more questions later on about this. That's okay. I'm happy about that. So I want to introduce you to something where I think it's just incredible. If you had a technology where you could press one button and cure glaucoma, you press one button and phew, just like Star Trek, no more glaucoma, wouldn't that be amazing? We'll enter the direct SLT, or the direct selective laser trabeculoplasty machine or technology. And essentially, this is, to me, the closest thing that is just like Star Trek, where you could press one button and take away someone's glaucoma. Now, unfortunately, it's not quite at that point yet, which is probably good, because I'd lose my job because I wouldn't have glaucoma to cure, but that's okay. But at the same time, this is an incredible upgrade to our technology that we've had for a while now. We've had SLT for a while now that we've talked about earlier, has been able to increase the amount of fluid outflow through that canal by massaging it and allowing that fluid to flow through better. And this here is an upgrade of that, where we don't have to put a lens on your eye anymore. I just have you put your chin on the chin rest, and I press one button, couple seconds, boom, you're done. And this is incredible technology that we at Moran were the first academic institution in the entire country to have this technology. And we are still one of the very few institutions in the country, and actually one of the few places in the country, period, to have this technology. And it's because of all of my colleagues here and their influences to be able to get this type of technology to us first and foremost, so that it's offered to you before almost anybody else. I Care Home?
Yes.
Okay.
Mention that study.
Yes,
Thanks,
I'm
Austin.
also going to mention the I Care Home. So my wonderful colleague here, Dr. Wirostko, she created a company to be able to take home one of the devices that we use to check eye pressure in the clinic. We teach you how to use it, and you take your eye pressure at home, which is really valuable information because sometimes we're not getting the pressure that that is actually happening back home. And so we have a study going on where we're looking at the pressure elevations that are occurring either just at baseline, what your normal eye pressure elevations are. Then we do the laser on you, one click, boom, done, right? And then we're checking to see what your pressures are doing outside of the clinic. And it turns out that many of these cases are the eye pressures are being flattened or reduced by just doing this laser. So we're kind of proving that as well through her company.
And there's a lot of work now that came out of the UK and Moorfields, a large study showing that the SLT and these lasers done, earlier on actually are very good at slowing down progression. And it may be that they're reducing the fluctuation. But what if laser's not an option? And what about it's time for surgery? So what is interventional glaucoma, Dr. Garakani?
Hi, everyone. Pleasure to be here tonight. Thank you all so much for coming. When we talk about interventional glaucoma, it's really a mindset shift that has happened over the last decade or so within the community of doctors treating glaucoma, where instead of keeping patients on drops, as long as possible until we're really seeing definitive progression, and then taking them to the operating room, we've actually found through a lot of landmark studies, some conducted here in collaboration with our research team, that earlier intervention with laser or even surgery ends up better in the long run in terms of your visual field progression and the number of drops that you need to be on for your glaucoma. And so minimally invasive glaucoma surgery, or MIGS, is kind of a new collection of surgeries that have come up in the glaucoma landscape, where we are oftentimes augmenting the natural flow of fluid out of your eye or creating a new channel for fluid to flow with really microscopic devices. These are sometimes, the size of a grain of rice or even smaller, that we can implant in a safe and effective way in the operating room. Sometimes these are done in conjunction with cataract surgery as well, so we can knock out two birds with one stone. And these procedures earlier in the disease course have been shown to improve outcomes in the long term.
Great, thank you. So I could imagine when I get cataracts, if I have glaucoma, you may say to me, I can offer you cataract and a MIGS stent at the same time?
Absolutely, yeah. Like I said, some of these stents are tiny. They add just a few minutes to your cataract surgery. And we've actually found that cataract surgery alone can reduce your pressure to some extent, but including a MIGS procedure brings that pressure down even lower. And so it's a really effective option that's out there for patients now.
And gets you off medications, perhaps.
Potentially.
But many of you probably know or have family members or yourselves, sometimes the drops aren't working. Sometimes MIGS may not be an option, and sometimes you need more invasive surgery. And my surgical colleague, Dr. Chaya, who's studied a lot of these procedures and actually is spearheading a pivotal study here at Moran, is going to talk to us about what's the next step for surgery.
Yes, thank you so much, Barb. One of the challenges that we have when we're managing patients with glaucoma is finding what we call the target pressure. Where do we want your pressure to be in order to reduce your risk for progression? And sometimes, despite medications, despite laser therapy, patients still progress. And that's when certain types of surgeries may be indicated. Not too long ago during my training, I really only had two major options to bypass a patient's plumbing system for their eye. That was either a trabeculectomy, which is a traditional procedure where we create a flap, or a tube shunt surgery, which is a little bit more aggressive, a larger device used to divert fluid into that space that we call the subconjunctival space, which is just under the outermost layer of the eye. But we knew that for some patients, that type of surgery could be too aggressive and there could be potential complications. So hence, we've innovated, the entire industry has really tried to innovate to create a standardized way to create a type of surgery where we can reduce pressure in a predictable fashion to a low target. This is one of the devices that we're excited to be researching here at the Moran called the PreserFlow microshunt, which diverts fluid into this space. One of the beauties of the technology is this is a special type of material that has already been proven in other areas of medicine, including cardiovascular medicine for stent technology. The advantage of this material is it's less likely to create some sort of inflammatory or scar tissue reaction, which can be very beneficial for this type of glaucoma surgery.
And the PreserFlow has been available outside of the US. In fact, Dr. Ahmed does it routinely up in Canada. It's available rest of world, UK, more fields. But we yet to have it available, right? So hopefully this study will help us offer it to our patients.
Correct, yes.
So we've got all these innovative technologies that we are able to offer you. Why? Because they are approved or cleared. But now we're going to invite my research panel, so I'm going to have you guys switch. Thank the clinical panel. And my colleagues here are going to tell, come on up, Adam, about how are these innovative technologies actually becoming available to you. So where does it start? Who's doing this type of work to figure out how does that laser work? What piece of tissue is it working? What is the best polymer or plastic or silicone on some of these shunts and tubes? So a nice segue from Dr. Chaya. He's got the PreserFlow study going on, but there's other ways that we can bypass that outflow system or that drain, right? So we're talking about that drain, that angle, open angle. If we need to bypass it, what else is in the pipeline? So Dr. Pitha, you've been doing a lot of work in this area.
Yeah, no, so I think one of the reassuring things about glaucoma, it's really a very small proportion of our patients who actually lose vision or go blind from glaucoma. And I think, one of the reasons of that you've just seen, right? Like we have so many medicines that we can use to treat glaucoma. We have a Star Trek laser, love that. We have MIGs, and then we have, more invasive procedures when those are necessary. But, what drives, my investigations, I'm a clinician scientist here, and I've been here for about a year and a half, is that I think there's a lot of room for improvement and innovation in the glaucoma space, whether it's improving the way the medicines that we use are delivered or making our current surgeries safer or just, more amenable to a quicker recovery for our patients. So I work in the Crandall Center for Glaucoma Innovation with Dr. Ahmed in kind of evaluating new approaches to treat glaucoma and new ways to innovate it. And I also have my own lab that investigates some of the basic science of these kind of questions. One of the really exciting things I get to do here is I get to collaborate with a lot of industry partners. And sometimes those industry partners are like multi-billion-dollar companies that have innovated in this space for many, many years. But sometimes it's a couple people working out of a garage. And we're actually working with a couple people working out of a garage right now. And the technology that they're developing is actually one of the most exciting technologies that we're kind of exposed to right now. So for the past year and a half, we do a lot of collaborative work with these industry groups. We want to kind of lend the expertise of all our glaucoma providers here and also use some of the expertise that's been developed here at the Moran Eye Center to really help these industry partners kind of develop their implants or their treatment approaches and evaluate them in a really rigorous scientific way. So that's a really exciting thing I get to do. And then the other thing I do, am I running over? Sorry, is I run my own lab and I look at some of the basic science of how we can improve our devices. And one thing we're doing, just a small thing, is we're looking at how the texture of these different devices can kind of alter the healing response. And it's really amazing, by modifying the texture, you can really alter the way patients heal from their surgeries. And we're looking at ways we can kind of fine-tune that to really optimize the patient experience.
And I noticed Dr. Pitha kept talking about collaborative work. So one of the questions that a lot of these collaborations or industry or sponsors come with is actually, how does the outflow system work and how does the angle work? And this is where Dr. McDonnell actually excels and is a world leader in this area.
Thank you for that, world leader. So my name is Fiona McDonnell. I'm a basic scientist here at the Moran. I've been here 3.5 years now, so I'm a relatively junior person, but I have been fortunate to be exposed to some of the world leaders in the outflow system. And so fortunately, Dr. Zabriskie actually covered a lot of this earlier, so I can give you the briefest of overviews, which is that the aqueous fluid that is formed to keep your eye healthy exits through that conventional outflow pathway. But in glaucoma, this pathway becomes clogged or blocked or dysfunctional. And so the role of my lab and my research is trying to figure out how it becomes dysfunctional and how we can try make it functional again to restore proper outflow and lower the pressures. The other thing that I do is I work with some of these industry folks, along with Dr. Pitha here, and I use this iPerfusion 3 system on the right of the slide, and this enables me to take donor eyes and measure the pressure, the flow, and then we can test these devices in these eyes before we bring them to patients and see how well they're working. Sometimes we can even see how they work. And we're able to, give that feedback to our industry partners and make some improvements or do some tests that help them be able to bring it to the market and to the clinics here in the United States.
And what's really important about that, too, is that enables us to do clinical research. So some of these studies that are done here with some of these novel devices, we are then looking at the outflow. And it really is interesting to see the collaboration and how you guys work together. And devices are cleared. So we're talking about some of the devices, and drugs are approved, very different regulatory paths. And Dr. Krizaj has been working on this for many years now. And we were chatting a little bit before the event. And we've known for so long that pressure is important. So 50 years we've been discussing pressure. But really, what is happening with pressure inside the eye? If you put pressure on an elastic type system, on a trampoline, on tissues, you can stretch it and damage it. But inside the eye, maybe you can help us understand what is exactly going on with the pressure, and how are you going to help us look beyond IOP?
Yeah, thank you. I would just like to note that Dr. McDonnell was very modest. She is a leader in the outflow field, and people from all over the world are coming here to learn from her. So we are very lucky. Well, glaucoma is a fascinating disease. Because it involves two locations in the eye. It's unlike any other blinding disease. So in front of the eye, where pressure is regulated, and Dr. Zabriskie introduced that, and in the back of the eye, where the retinal ganglion cells, which are out of hundreds of retinal neurons, retinal ganglion cells are selectively sensitive to pressure and die in glaucoma. So what you would want ideally is you would want to lower the pressure and protect retinal ganglion cells from pressure, right? And right now there are no neuroprotective strategies because we didn't understand how the cells sense pressure. And another interesting thing is that the reason, if you measure pressure in each of us when we are babies and until we die, it's pretty much the same. That's because these trabeculometric cells that were introduced earlier are pressure sensing, and they are actually regulating pressure throughout our lives, and glaucoma comes from dysregulation of this pressure. What is amazing, again, we didn't know how this pressure is being sensed by trabeculometric cells or retinal ganglion cells. What we completely by accident discovered in my lab is that both trabeculometric cells and ganglion cells expresses highly specialized pressure sensor, an ion channel that is regulating pressure, and we find that we can elevate pressure in dozen different ways. And we collaborated with organic chemists at University of Utah to develop new eye drops which lower pressure in all of these models. So not only that, we also got funding from, we established a company with Crocker Ventures, which is a VC firm from Salt Lake City, and developed a slow release platform based on the structures called liposomes. And when we inject this into mice eyes with glaucoma, pressure comes down and stays down for months. And 1 week in a mouse is like 1 month in a human. So the idea is that you can use this without, so if you can use this, you don't need eye drops anymore. You get 1 injection a year and pressure goes down. And what is amazing about this is that we find that these compounds also block the pressure sensors in ganglion cells. So now, for the first time, we can actually prevent the neurons from degenerating no matter what the pressure is.
So we may actually have a neuroprotective compound. And I think something too that you mentioned, so we didn't go over, I don't know how clear this was, but the OCT, what that measures is exactly what Dr. Krizaj is referring to, is the retinal ganglion cells. And when you have a visual field defect, again, that is the retinal ganglion cell. So again, it's these cells in the retina that are susceptible to the pressure. But yet we always lower pressure at the front of the eye. And I think what's fascinating too is we always focus on this as a ocular eye disease. But yet what you're hearing is optic nerve, connections to the brain, visual field defects are, it's a loss of the vision, but again, it's related to how the brain is seeing. And the work of Dr. Davis, actually, he's going to talk a little bit about how is your work going to help these patients? And why do we not focus more on the brain?
Yeah, that's a great question. Thank you. It's a pleasure to be here. So yes, I'm a basic science researcher, and my focus is in visual perception, which is a product of the brain. Light sensing occurs in the eye and the retina, as you've heard about today, but vision as we experience it is a product of a complex process in the brain. And what's really interesting is when we think about damage to the retina, we think about like a hole, like a gap in how we sense the world. And the brain abhors a hole. It fills in whatever information it can muster to give us some intuition of how the external world exists, because we know that the world continues to exist even if we aren't looking directly at it. And so one thing that is known is that glaucoma patients not only have disruptions in the function of their eye, but there are also changes that occur in the function of their brains. And so what this means is that the brain is changing and adapting to try to compensate for that vision loss, and this can lead to distortions or alterations into how they perceive the world. And so my goal is to study that process both from a basic science level, just understanding how the brain builds those representations of the world, and then by understanding how that changes in glaucoma patients, we can gain some insight into either avenues for early diagnostics, signs that there might be evidence of these alterations occurring. And one example of that is in eye movements. So, we move our eyes to collect information about the external world, and patients who have damage to the retinas, their brains become sensitive to these gaps in their ability to collect information, and so they alter the ways in which they explore their worlds, or perhaps even they alter the ways in which they represent space as itself. And so by being sensitive to these changes in ocular motor behaviors, we can track and perhaps gain insight into not only the etiology, but the consequence of these losses of vision in the retina.
And what about depth perception? Because that's another thing that patients will experience, right?
Yeah, the contrast loss, I think, is a big one, and depth perception is another one. And there are particular integrative pathways in the brain that takes the information from both eyes and stitches them together to give us estimates of depth. And so understanding how stereoscopic vision is being altered in glaucoma is another way in which you can gain insight into things that might not be sensitive on a traditional visual field test, where you want to know explicitly where the damage is in each eye in separate, and by looking in these types of depth measurements, you might be able to get insight into how things are being integrated into the level of the brain. Because once you lose that information, how those circuits are formed to calculate depth might be changing as well.
It's really cool stuff. So, and finally we come to Dr. Dubis, and he's actually looking at big data, but also AI. And I asked him, so what kind of question would you like to be asked? And he said, will AI replace doctors?
So thank you. I'm going to answer a question and come back to that one. Many of you are seeing my amazing colleagues here at the doctors. You're sitting down, the doctor comes in, there's a nurse talking to them, saying some information. They sit down at the computer, they're looking at this tab, they're clicking here, looking at this tab, all the while you're trying to explain to them what's going on. In these amazing physicians' heads, it's sort of like those cartoons with those little math equations going. They're trying to process all this information you've heard about today. These images, these visual fields, all these new techniques, everything that's going on. And they're trying to figure out what's going on for you. And on the chart up there, you come in this week, you come in a month, you come in 2 months, you're coming in sequentially. They're looking up all that information about you. They're reflecting on the tens, the hundreds of patients that they've seen this week, this month, and they're trying to figure out what happens next to you. So you're following this little orange line across the screen. And they look at that information, they try to figure out what's going on. Now, what if they had the option of, rather than reflecting on that 1,000 patients that they've seen, what if they had all this information that my colleagues talked about? What if they had the access to the 24,600 patients with glaucoma that are being seen here at the Moran? What if they had access to the 1 million patients that my colleagues and I have access to? What if they had all that information to figure out what's going on? And as you chart that orange line across here, you see that it gets thicker and then it comes up to a couple of different options on the side right behind me here. And those are the probabilities of what happens next. What if we had the ability to give that doctor that 1 million patients worth of information so we know what happens? We know when a person follows this trajectory, they're not alone. There are 1,000 patients at the Moran that are being seen like you. There are 10,000 patients at the Moran that are just like you. We know that in those 10,000 patients, this is what's going to happen with a mathematical certainty. That's what my group is trying to do. So I was lured here 2 years ago from London, from Moorfields in London, by all the data and by the amazing colleagues that I have here to try providing those answers. And so I've spent the last 2 years harnessing all that data, cleaning it all up, and now starting to provide those analytics so that hopefully in the very near future, your doctor will now walk in to see you, and they're going to have a very quick look, 10 seconds at the screen, all that information is in front of them, probability, what is likely to happen, what are the key pieces that they need to know, and they get to sit and they get to look at you and they get to say, Mr. Smith, how are you doing today? How are your eyes doing? Rather than looking at that computer screen. And it isn't that far. My work has already done that. We've done it in other diseases in ophthalmology where we've taken the 3 minutes of looking at the computer screen down to 15 seconds, and I'm hoping to do it here with glaucoma. So no AI is not going to replace your doctor. It is going to let your doctor be what they are best, the empathetic, compassionate human who understands you, the person sitting in their chair.
Thank you, Adam. So along those lines too, do you envision with all this data, and I think, the audience has heard, we mentioned polygenic risk score, we mentioned outflow, we mentioned receptors, we talked about different medications, and you may know one medication maybe worked on you, one didn't, right? So I would imagine that we can get to a state where we have personalized care.
Absolutely. So just on the page up here, that little orange line is one person's track through the glaucoma service here at the Moran. So yes, we will know for each of you, where are you tracking on this? Are you in one group? Are you in a second group? And are you by yourself? No one's ever by themselves. Are you one of 10? Are you one of 100? Yes, so absolutely getting to that personalized medicine with all the information available to them.
And selecting the right mix procedure or the right surgery,
Exactly.
right? Or knowing whether we should be doing visual fields every 3 months or every 6 months. It's that level of care. It's that detailed, personalized care package that we can offer you before, hopefully before vision loss occurs or a visual field defect. So with that, I'd like to thank everyone for being here, and we hope it was educational.